So, hello from Cambridge Biomedical Campus on virtual tour. I'm Jill Wilson, and wherever you are in the world today, welcome. These webinars showcase the people, the activities, and the buildings on the Cambridge Biomedical Campus, and they're not just for the 20,000 people who work here, they're for everyone. So please feel free to send these links far and wide. Today, I have great pleasure in introducing Mark Avery. Now, Mark splits his role at Eastern Academic Health Science Network and Cambridge University Health Partners. His role includes providing governance and oversight of information-based innovations which support clinicians to have the data they need at the point of care, and developing the capability in the region to integrate data to gain insights that inform health and care delivery and clinical research. He sits on the East of England Health and Care Record Programme Board and is the operational lead for Gut Reaction, the National Health Data Research Hub for Inflammatory Bowel Disease. Starting out as an information analyst, Mark has approaching 20 years experience working at the NHS across a range of operational, information, contracting and performance management roles. He's experienced in leading complex projects and programmes in acute hospitals and commissioning organisations. A very busy man. Can you please put questions as you think of them in the Q&A? Try and avoid the chat, and then we've got all the questions in the same place if you don't mind. If for some reason the Q&A isn't showing, then by all means post them in the chat. Mark will attempt to answer those questions after his presentation. So with no further ado, I'll hand over to him. Welcome, Mark.
It's quite a big topic, this one, in terms of looking at health and care data use by businesses or by commercial organisations. As I say, complex space touches on a number of different policy areas. There are a huge range of perspectives, and anonymisation of data, and then start getting into the different perspectives about how data are used, both from a public and patient perspective, but also in terms of wider stakeholder groups, so commercial organisations, NHS organisations, researchers, etc. So just to give a bit of an overview of what is shaping my perspectives or views on this. This is just a very sort of high-level summary of the work that the team are involved in at the moment, and we have a largely joint programme of work between Eastern Academic Health Science Network and Cambridge University Health Partners. And I won't go through all of these in detail, but we have been involved for the last 3 years or so with Gut Reaction. Jill mentioned this in her introduction, but this is a health data research hub for inflammatory bowel disease. So my lead as operational, or my operational lead role there, actually came to an end at the end of August, and the hub is now transferred under a sustainable model under the NIHR bioresource going forward. But it's a fantastic data resource of 35,000 participants with inflammatory bowel disease from 100 hospitals UK-wide who've provided consent for their health data to be used for research and to be recalled if necessary for particular studies. And we did a lot of work there getting more detailed longitudinal data or data captured over time from NHS organisations involved in their care, and linking that up with genomic data and lifestyle data. So there's a fantastic resource there, and a lot of interaction with industry and with patients over time that's shaped a lot of the perspectives that I'll refer to today. Other key projects for us are Synapse. So this is end-to-end architecture for storage, retrieval and processing of genomic data alongside clinical phenotypic data under the NIHR Cambridge Biomedical Research Centre. We've had a couple of DARE UK projects. So DARE, if you haven't come across it, is data analytics in research environments, collaboration between Health Data Research UK and Administrative Data Research, ADR UK. looking at proof of concepts really around this concept of federated analysis of data, so leaving source data where it is and analysing it remotely and pulling results through into a central secure research environment. So two fantastic proof of concepts there, one working with Synapse and Genomics England to develop a proof of concept for federated analysis of genomic data. And then another one that will be really, really influential, actually, called Fair Treatment, tackling the issues of integrating data across councils and across organisations for children and young people with potential mental health with potential mental health problems. So this is linking data between the NHS, education, and social care to identify people with a need. So from a governance, complexity, negotiation, patient engagement sort of perspective, that really provides us a model that we could scale and adapt for other things. And I will revisit this at the end, but there's a regional initiative now that we've just recently bid for money on for secure data environments, looking at integrating health and care data more broadly across the East of England region as a whole. So these are the type of projects that we're working on. There's clearly an awful lot of work with patients and the public about how we shape those. But ultimately, they also need to work for NHS organisations sharing data into them, academic institutions or commercial organisations wanting to access the data to answer particular challenges, and obviously doing that in a way that is legal, ethical, defensible, and supported by all stakeholders. So it would be remiss for me to sort of scoot over some of the challenges here, but there are some useful lessons to be learned from the past. If you look at the research, in fact, pretty much any of the research into patient and public attitudes to use of health data for research, almost universally learning the lessons from care.data in 2014, things that have happened since with Google DeepMind at the Royal Free, and more recently the general practice data for planning and research, GPDPR, termed by some in the press as this sort of NHS data grab. There are real lessons to be learned there about describing the benefits for why data are being used, but also the safeguards that sit alongside that to ensure that it's used properly. And I think all of these things have fallen down to some degree because people have had concerns about the downstream use and safeguards and assurances about the benefits that will be coming out the other end. I appreciate a number of people on the call will be all over the detail of this, I'm sure, but I think in case there are some that aren't, what understanding patient data called the spectrum of identifiability gives a nice overview, if you like, about the purposes to which data can be put, depending on how granular or how identifiable it is. So clearly, for professionals involved in the care of an individual, giving treatment to an individual, interventions, etc., you need to know, and you need to be absolutely certain that the person that you're dealing with, that you know who they are, and that you have the relevant information on them. When you get into uses of data for commissioning and population health management and the like, for the most part, that can be done with depersonalized data. There might be the odd instance where, in order to be able to follow up on specific issues or to address particular risks, you might need to go through a process of re-identification. But for the most part, that can be done on data that strips out individual patient identifiers. But still, if you're working at record level on data, then there are clearly going to be features within that that could, of themselves or linked to other things, re-identify individuals. So a lot of what we're talking about today is data in that sort of depersonalized or de-identified to depersonalized sort of space, where we're retaining as much of the utility and usefulness of the data for research and development as possible, but being appropriate in terms of the way we manage the risks. This concept of anonymity, and it's a term that we try not to use, to be honest. Anonymity isn't necessarily a binary thing, but the more identifiers that you strip out and the more you aggregate or group people with similar characteristics to count them together, the more anonymous or the more anonymous data becomes, and the harder it is to re-identify individuals. Once data are considered anonymous, if you like, then some of the legal safeguards around GDPR, for example, cease to apply. So they only apply to identifiable data, and we might come back to this a little bit at the end. But the sort of concept of how anonymized is anonymized enough for data protection sort of laws to not apply in the same way is subjective and contextual in some instances. You may also be aware of the national data opt-out. This still exists, I think, at 2 levels. Individual patients can opt out of sharing data or having data from their GP practices shared as one exercise, and also object to the secondary care data collected by NHS Digital being used for downstream planning and research beyond those things listed at the top of the table here, so beyond direct care and population health management. So the national data opt-out means that data will still be used for a number of things, but it will prevent the data or identifiable data being used for planning and research. Obviously, data that has already been anonymized could or may still be used. Okay, so just to give an overview of the rules that apply, and it's really quite difficult to try and get all of the information governance type requirements on a page, but this is an attempt to summarize it. So if we look at the top here in terms of what we're doing with the data, we're working from initial preparation of data provisioning around a particular research question, the process of extracting and collating that data, integrating it if there are other data sets involved, processes and steps for de-identification, and all of this, if you like, can happen in one type of environment where people within the NHS, if you like, are preparing data sets for research, and then there's the process of provisioning that then and making it available to making those curated data sets available to researchers at the back end. So there are questions here around, is the study research? And if the study is research, are there appropriate research ethics in place? And the Healthcare Research Authority is the organisation that oversees that on behalf of the NHS. And then when it comes to the sort of the types of legislation that apply, so the Data Protection Act is what we're talking about for the most part, but GDPR is enshrined within that. And essentially we need, for most healthcare data research, we need 2 legal bases for processing the data. So we need a legal basis for processing personal identifiable data, and then health data meets this special category requirement, which then needs an additional legal basis for processing. And there's a example provided here. So the personal identifiable data legal basis might be a task in the public interest. For special category, it might be that we're looking at scientific research, and we provided assurance that there are safeguards in place. But alongside this, there's the concept of case law, or the common law duty of confidentiality, which is complex and evolving because it is driven by case law. But I guess the core premise here is, if we can make sure that data are being used in the way that data subjects might reasonably expect or be able to find out about themselves, then for the most part that test will be met, and that's why describing what we're doing with data, having public dialogue around what we're doing with data, website privacy notices, data release registers, recording and making publicly available records of how data are used, all become really, really important. Now, there are certain examples where that common law duty of confidentiality may be set aside, where there's an overriding public interest, for example, and the control of patient information notice, or the CUHP notice that came out in connection with COVID data, for example, is one example of that. But otherwise, where if identifiable data or really granular, potentially re-identifiable data is being used for R&D purposes, if specific informed consent isn't given, then in order to be able to set aside this common law duty of confidentiality, then a clinical advisory group needs to give something called a section sort of 251 approval in order to be able to set that legal provision aside. There's a range of safeguards and de-identification techniques that can be applied to the data in order to be able to keep it safe. But really, I guess the message here is about making sure that there is transparency about how data are used. Okay, that's potentially a sort of a hefty topic, but I hope that helps in terms of an overview. So in order to be able to overcome some of those things, so if we've got the legal basis right, the data are minimized or reduced such that a researcher is only getting access to the data that they need to be able to answer a specific approved question. Then we get into looking at the environment in which that data is provided, and there's been a lot of talk recently about in the last few years about trustworthy research environments, or TREs. That language within the NHS now is evolving into secure data environments, or SDEs, which I think is better actually, because it sort of encompasses the preparation and provisioning of the data, rather than just the environment in which the research is taking place itself. And for the most part, we're looking at cloud-first type architecture for this, and VDIs, or virtual desktop infrastructure, is proving favourite, and this is essentially being able to give people a secure web link to a virtual desktop. So this is a normal desktop appearing in a browser window. It's probably the easiest way of describing it, with whatever operating system is needed and the tools that are required to analyse the data. But effectively, rather than large data sets being shared, what you're seeing are pixels of a virtual desktop with the data actually residing elsewhere. So it's very easy then to control the tooling, the security around the environment in which the data is kept, who has access to it for how long, etc. through that kind of mechanism. Okay. So let's get into some of the wider perspectives and value propositions that are involved in either data sharing or allowing data access. This is a really complex space, and actually talking with different organisations, whether that's researchers or commercial organisations or patients or individual NHS trusts, people that are working wholly within their environment, will see things predominantly from their own organisation's perspective in all of this, without necessarily appreciating what others will need and want to be able to see. And we'll unpack this in a little bit more detail around some of these stakeholder segments. But clearly, industry want access to the data to be able to develop new innovations and treatments that will ultimately benefit patients, but also there may also be a commercial benefit. Researchers similarly want the same thing from a data access point of view. NHS organisations would potentially see the benefit of those things, but as data controllers, they bear an awful lot of the risk in terms of, if there were sort of actual or perceived misuse of any of that data downstream. So the NHS organisation sort of motivations in this is really, really key, both from an NHS trust or provider trust perspective, but increasingly so with primary care, and GPs probably hold the most comprehensive, holistic information about individual patients. But there are so many individual GP organisations that negotiating with them individually is impossible, and attempts to try and do those things globally, so far have been really, really difficult. And again, supporting those organisations to be able to see and feel and realise very tangible benefits from their data being used or access to the data being allowed in a way that outweighs the risk to those organisations remains a huge challenge. Taxpayer perspectives. Obviously, patients and taxpayers are often the same, but the perspectives are very different. So as a taxpayer, I expect data to be used in order to make efficient use of NHS resources. As a patient with particular information about me or my family, I might feel slightly differently or need different levels of assurance about how that data are used. If we just get into the patient and public views a little bit more, there's a fantastic piece of work that this is 2016, so obviously a few years old now, but I think still one of the best and most comprehensive studies around patient and public views on data being used by commercial organisations for research. And within that, this is one particular slide, but it's a fantastic one, I think, for summarising what drives acceptability around data being used. So on the left-hand side here, we've got where there's a clear public benefit from the data being used. It's being used by public health providers, and it's either used in terms of aggregate counts, or the data is sort of passively collected as a consequence of what's happening anyway. That is at the much more acceptable end of the spectrum. For the most part, when we're talking about use of data for academic research and then into commercial R&D, we're increasingly dealing in this slightly more complex space in the middle, where there's a mix of public and private benefit. There may be some profit motive involved for some of the organisations, and the more going back to the identifiable data issues, the more granular the data, the greater this risk of what's called jigsaw ID, so being able to re-identify individuals based on information in other sources. The other thing that was really clear in all of this is that there are some really clear red lines. So if there's no obvious patient or public benefit, if there's solely a profit motive, or there are potential real-world implications for example, life insurance, or disclosing information about other family members that might have unclear downstream impact, those are really clear red lines in terms of public feedback. And there are other areas that still now need further conversation and debate in terms of downstream or secondary uses of data that might be put together for one purpose, and use of genetic data is another really, really complex area. Building on some of my own analysis then into some of those sort of survey results around this study, the thing that came out, or the feature within the survey responses that was most closely linked to public support for data use by commercial organisations was the extent to which individuals recognise that the data has value to society, in that it can help improve things for people other than me. And this is what's called an ordinal scatter plot, but essentially each dot in each of those boxes is an individual survey respondent, and we can see that as across the bottom of the screen here, but as there is stronger and stronger agreement that people make the connection between their data and the value it can have for other people, so their support for data being used by commercial organisations increases. And from a probability perspective, this is really highly significant. So it really underlines the need and the messaging really about making sure that the benefits and the intended benefits of any research at all are really clear from the outset. So we've got a situation whereby having assurance around the safeguards of data may stop people opting out of research taking place, but we're really only going to get really active support and advocacy from individuals and patients that are prepared to stand up alongside us to advocate for the use of data for a particular purpose, and that's where we get the real support. The model around the 5 safes is a really useful one to refer to, and again, if you haven't seen this already, originally developed by or adopted, I think, by the Office of National Statistics. I think developed in the sort of the University of the West of England, I think, originally. But they look at this sort of concept of 5 safes in terms of it's not just safeguards around the data or around the environment that it's provided in. There's safe people, safe projects, safe settings, safe data, and safe outputs. So that we're ensuring that the people that are accessing the data have are legitimately accredited and have a legitimate reason for accessing the data for a specific and approved use, which is the safe projects bit. So data are only made available for ethical research that delivers that clear public benefit that we've talked about. That the setting in which the data is provided is appropriate to the disclosure risk that is inherent within the data itself. That the data have been de-identified or redacted and reduced as far as possible, so things that aren't adding value to the research aren't included with the data, and that the outputs in terms of what's published are checked to ensure that they cannot themselves be identifiable. And one of the things that the University of the West of England have done, and there's a link on this, and I know Jill will be sharing some of the slides afterwards, but it's this, so there's a link to the research paper around this, but this concept of being able to dial up and down the protections in each of that space, depending on the context of the particular research question or the potential re-identifiability of elements within the data is quite important. So clearly, if you're working with identifiable data for with consent around it, perhaps it's being used for a clinical trial, then the setting and the people and the outputs are really important. Those protections need to be really high because the risk within the data is high. If we're dealing with really heavily de-identified or aggregate data, like the number of A&E attendances for or particular types of attendances or admissions over time that are being reported as quite high level counts, then clearly that's very safe data. You don't need the other protections, and in fact the data could be published and made widely available. So I think the dealing with privacy in context as a principle is an important one. Okay. So here is an example of, I talked about the need or the importance of patients being able to stand up alongside researchers and people leading these projects to be able to show and demonstrate that they have been involved, they understand how the data is being used, and they're actively shaping how decisions about its downstream use are going to be made. And clearly that's the best way of, well, making sure that we do it correctly in a way that will be supported by patients and the public, but also being able to demonstrate how they're involved in that decision making. So here's a summary on this slide of the process that's been put in place now. So initially this was developed by the patient advisory committee that was supporting on gut reaction. So this is sort of the output of nearly 3 years sort of worth of work and discussions. But this model now of there's initial application, there's a technical triage, if you like, to check that whatever request being made is complete, contains all the information that it should, and is technically viable, if you like. And then the governance, ethics and patient and public support is sort of tested by this patient and public review group, the PPRG, before it then feeds into either a data access committee or in this case a steering committee for commercial use cases, with patient and public involvement in each of those committees, and ensuring continuity between them. So this has been a really good model. As I say, it was developed for gut reaction. The NIHR bioresource are actually now using this across the bioresource as a whole, which has been one of the big successes, I think, the gut reaction hub program. Okay, NHS organisations. I talked about the risks here, and the risks that's carried by organisations as data controllers. I think it's also worth making it clear that the policy landscape and the rules about how data can be used are to be frank, really quite complex and involving and difficult to keep track of in terms of what's coming from where. So if we look at some of the policy from the gov.uk website, for example, there's relevant guidance coming out of the Department of Health and Social Care, but also Department of Business, Energy and Industrial Strategy, and also for digital, culture, media and sport, that are all relevant, and then interpreted. So some of these have slightly different lenses, and I think everybody knows and understands the potential for patient and public benefit around supporting commercial engagement for research. But again, these are written with slightly different lenses and slightly different priorities. So as organisations that are accountable for the use of data, at the back end of this, actually negotiating policy developments and requirements alongside the legal and ethics requirements and common law requirements, means that the burden on individual organisations to make sure that data are being used in a sustainable, ethical, legal way. To be frank, it kind of, well, that alongside the risks of getting it wrong, mean that all too often research that could go ahead doesn't, simply because of the effort that would be required to put into finding a way to be able to do it in an entirely defensible way. So it's a very real challenge that we're trying to support. Okay, so from a researcher perspective now, pressing on, again, if you haven't come across FAIR principles already, it's a really key basis for what we're trying to do here. So researchers, be they from academia or industry, want data that they can find. There's a clear process through which they will be able to access it. It needs to be interoperable, by which we mean either linking up with other data sets that contain some of the same data items, knowing that you're counting the same things in the same way. There are a series of data standards, both in terms of APIs and in terms of individual data sets. But the interoperability of data is absolutely key if we're wanting to make use of data at scale. And the other thing is about making sure that data and curated data assets, particularly, are, where there is appropriate governance in place, reusable. So those FAIR principles, I think, are key to the secure data environments work that we're putting together. In terms of findability, and again, this is an example from the Gut Reaction project, but the Health Data Research UK has an innovation gateway where you can, as a potential researcher, you can search for data and data sets across a whole range of themes and organisations that are signed up to the Health Data Research UK Alliance, all contribute data and data sets to this. So this supports data set discovery. And in order to be able to frame a research question appropriately, researchers need to know what the content of those data sets are, but without that in itself being disclosive. So ways of creating data catalogues, data dictionaries. In this case, there are some outputs that we used for gut reaction, as I say, in terms of health and lifestyle questionnaires, genomic data, the data that was being captured from NHS trusts, whole genome or whole exome sequencing data sets. In this case, so describing what's available and in what type of quantities overall. And another really helpful concept in that has then been looking at how those data sets overlap or intersect, to get a feel for what the available cohort might be within that. Now, a step beyond this is a step beyond data set discovery is cohort discovery, which might mean that you can actually sort of query the intersect of all of this data, but just to say, right, well, how many I don't know how many men are there over the age of 45 with a particular genetic variant, and this, that, or the other has happened to them in their clinical pathway to date, and actually being able to identify whether that number is big enough to be able to support a research study really can really help researchers shape the research question or the data access request that they might pull together. It's important to pick up in this commercial perspectives. And again, reflecting on our experience from the Health Data Research Hub for IBD, for gut reaction. Each dot in this chart on the left represents a meeting that was held with a commercial organisation, and we met with a whole more than 80 sort of organisations across pharma, biotech, medtech, membership organisations, both large multinational organisations and SMEs, and a huge amount of time and effort went into those meetings, describing the type of data that was available, and really those conversations have shaped some of the outputs that I've shown you just now in terms of intersectionality of data and what have you. But it takes an awful lot of time and effort. So the top table on the right then shows the number of those discussions that actually progressed beyond initial engagement to an actual sort of data access request being made. So I think we are not yet well configured in terms of being able to describe the assets that are available, but also having the sort of the mindset and the speediness of response and the customer relationship management type approaches to be able to help guide commercial organisations through the process. And certainly a massive challenge is being able to respond, more quickly to organisations that just in terms of their bottom line can't afford to wait. So SMEs particularly need really quick turnaround, and that doesn't fit with the data access provisioning agreements type process that exists if you need to work all of this through from scratch. But it's worth being mindful of what we need to get to. So I think conversion rates are low. It takes a huge amount of effort. And actually in terms of customer relationship management and actually delivering things that commercial organisations need to be able to bring new innovations to market is an area where I'd say it's a challenge, but there's huge potential for improvement or growth, I guess. Okay, and a quick one. So almost as we round up, but then what type of commercial models can we build around the data being used, again, in a way that's open and transparent, sees some commercial benefit coming back to the NHS frontline originally? So is this thing of, right, well, there might be commercial value from an innovation, but actually if that's significant, that should be shared with the NHS or the organisations that are involved in providing data in some way. And we had a lot of conversations with HDI UK and other hubs and other organisations sharing data. And this slide was one that was really, really useful in terms of supporting those conversations. So if we're looking at income streams, if you like, they can either be service-based, so we can have, you know, a fee, if you like, attached to you know, the provisioning and access to particular data. We might think about service fees in terms of, you know, additional value or extra preparation that needs to be done to the data in order to be able to make it suitable for a particular service. So that might be data curation, it might be access to particular tools or bespoke software, or development or data engineering skills, in addition to the service provisioning. So there's a sort of a service-based cost model. And then there's this one that sees the benefit either of a, you know, of a very large cost saving elsewhere, and you know, longitudinal follow-up of patients that have been part of clinical trials, for example, is a huge area of potential cost saving for pharma. Or, you know, development of new products and treatments could, you know, globally lead to huge revenue potential. And, you know, on principle, the NHS would like to see some benefit from that. I think in reality, though, certainly from our conversations, we've focused pretty much wholly on the left-hand side of this table, because actually being able to value data accurately, or anything like accurately, you know, in terms of linking outcomes back to the benefit the data itself has brought, is a really, really difficult thing to do. It takes an awful long time to realise, and particularly if, you know, I don't know, one data set is, you know, just maybe part of the picture that has led to a solution being developed. How do you attribute the right proportion to data that's been provided in a particular case? So I think that's likely to be too hard. It needs to be built in, you know, in some way to the access fees up front. And obviously there are also broader benefits to the NHS and healthcare organisations if, you know, new products are or treatments are developed in a way that benefit patients. Just wanted to pick up what we're doing, you know, locally to try and bring and tie these things together. So from a Cambridge University Health Partners point of view, we've been developing our data strategy. The central purpose around CUHP's strategy is around improving lives through supporting discovery, delivering new and innovative treatments and demonstrating their efficacy. And data is, you know, one pillar across, you know, a series of enablers, from talent networks, finance, and place and environment that can support those things to happen. But particularly from a data point of view, we've got this really clear interrelationship between use cases, and this ties things back to being able to show the benefits of data being used to patients and the public, and the insights and either improved understanding of mechanisms of disease or development of new products or services, or their potential downstream, or the potential for that happening downstream, you know, is really, really key in those use cases. So people make the connection. You know, it's the point of it all, essentially. And then there are a number of use cases that we're working on in that space. There are then a series of technical components. We've talked about information governance and a little bit about how we prepare and describe and make accessible those data products, and the data infrastructure that we provide access to that data through. And then we've got a series of operational enablers there, clearly around people and talent, coming up with models that are suitable and replicable from an adoption point of view, and also being able to support their scaling and outreach. And finally, and I'm not going to dwell on this slide, but we are looking at tying those elements together at the moment with an application for central NHS funding to think about how we might be able to bring data assets together from the 6 ICSs in the east of England, in a joined up way to support that discoverability, findability, or all of the FAIR principles, observing all of the 5 safes in a way that that will support innovation and discovery, but in a way that is supported by patients, the public, and and NHS organisations that provide data into it. It would be remiss of me to say that that's not without its challenges, though. There's a huge amount of sort of work and conversation that needs to happen with patients and the public about how this will work, to make sure we're doing this in a way that is that is supported, and people are clear about how they can opt out and what that means. We've got principles of engagement from NHS organisations across the patch, but I guess the devil will be in the detail about how that works and how risk is borne and how benefits are realised, and clearly around funding the architecture and the information governance, particularly where linkage is required for data across organisations, or a data access committee might be making decisions on behalf of more than one organisation. If you like, those things become quite challenging. So it's not without its challenges, but clearly, if we want to be able to support innovation and commercial organisations' use of data into the NHS, then I think this takes us in the right direction. So I will stop there, and Jill, if there's time, it'd be good to pick up some questions.
Indeed, Mark, that was fascinating. So much information there. Thank you very much. So we have got some questions in. Let's have a look. Somebody told me that the DAC SDE data holders switched from a default no to a default yes response to data access requests. Do you know about that?
No.
Okay. Right. Anything else you want to say on that, Mark?
So I'm just sort of reflecting. So okay, so I guess this is really a question, I guess, about whether there is a sort of a default sort of permissive view about how data can be used, or a default way of trying to find a way through. I think for the reasons that we've described, I think from an individual NHS organisation perspective, perhaps in the past the default has been no, but in order to be able to say yes, you need to do quite a lot of work to be able to show how the safeguards and things are in place. So I think if it would be good to be able to move towards that default yes position, but heavily caveated by making sure that things only get to that point because they have been through checks and processes already.
Yes, it's been very thorough.
A particular process. So if things follow a sort of a proper process, then by the time they reach a data access committee decision, all of those things are in place and addressed. So I definitely think it's a sort of an aspirational view, but not a not that we should be necessarily permissive by default, if that makes sense.
Somebody's just come in on that. Wasn't the data access default about patients accessing their own data via the NHS app?
Okay, I don't know, and there would be people other than I didn't want to give the wrong information around the app.
That's absolutely fine, Mike. Only answer what you know about. Another question: can you talk more about sign-ups for sharing genome data? How does it work?
Okay, so Synapse is reasonably early days, but I think it offers sort of fantastic potential. So one of the big challenges with genomic data is that the source data files are so huge. So depending on the read depth, if you like, the whole genome sequence for me, if you like, might be somewhere between 94 to 160 gigabytes in size. And obviously, if you're looking at that across 100 or even 1,000 patients, that becomes quite a challenging thing to be able to deal with. So what tends to happen with genomic data is it's chunked up into smaller elements that either look at differences in somebody's genome compared to a reference one. So obviously that cuts down because you're only looking at variations, or you're looking at particular parts of the genome, or these sort of variant files and variant stores and things, which might become much smaller usable bits of data, and they're potentially reusable. So I guess one of the key points there around around that use is being able to preserve the provenance of the data. So where you're creating some of these smaller outputs, you've still got to be clear about where that's come from, and the coding that's been applied to be able to get there. And because they are so large and processing them can be quite, storage can be expensive when you're looking at volumes, but also processing or compute costs across that data can be expensive. So you don't want to replicate the production of these things where they might exist. But again, back to the FAIR principles, they need to be findable and discoverable and what have you. So being able to run these data sets under a particular research group helps supporting them with their research findings, but then making both the source data and the sort of the staged other data outputs, VCF files and the like, potentially available for wider work is really the premise behind it. So I hope that helps. With, as I say, relatively small scale. We're working with 4 research groups at the moment, looking to see if we can scale that out over the next sort of couple of years with the NIH Cambridge BRC.
Thank you, Mark. We've got a comment stroke question here. Small medical device companies might have much less money to spare than big pharma for accessing the information. Initially, I thought the idea of profit sharing or payment as milestones are crossed would be a model that would work well for a small company. However, this has been seen to be difficult to administer. How would the cost be affordable by a small company that needs to access the same data as a large company in order to develop its new technology? Is that within your realms of expertise?
It's certainly come up in conversations, and it's a really good question actually. So I mean, I guess there are some different routes to trying to secure funding to support these things anyway. So in some ways this is what sort of research grants or central funding sort of proposals can help deliver. If there's particular investment revenue potential from particular innovations in the space, then then obviously venture capital or wider investment is another source of funding. But actually, I think when a hub has reached a point, a hub or a service like this has reached a critical mass where core services are being paid for in a way that they're covering their own costs or even contributing to the development of those costs, then actually, if that's working for on a not-for-profit motive, if you like, then reinvestment potentially of those pools in terms of being able to subsidise things that are of particular benefit, or being able to cover that shortfall, entering into a maybe a revenue share type agreement or an equity share type agreement with smaller organisations where upfront payment might be more of a challenge. So I think all of those things are possible, but it's difficult to be able to bear those costs until a little bit further down the line, I guess.
We've got 2 minutes left, so probably time for just one question. Could the need for speed when responding to data requests from SMEs and even larger organisations ultimately undermine the safeguards that we put in place for patients and the public? Is there a risk that safeguards are circumvented or glossed over in order to meet commercial needs?
Okay, so I think in terms of the processes that we're setting up, in 2 minutes. So in terms of the processes that we're setting up here, and I think the assurances that individual organisations that are carrying the accountability will need in order to be able to play ball, then I would say no. We can't afford to compromise some of those things. That said, in terms of some of the wider policy decisions and decisions that are being made on a national level, we have a huge problem with COVID and long waiting lists and the like at the minute, and there are things sort of hitting the sort of deadlines today about Palantir as an organisation, for example, potentially using or supporting the NHS to help manage that waiting list problem. So I think it would be naive to say that those risks don't ever butt up against each other. I guess in reality that they do. But I think if we're looking at a sustainable output here, then clearly acting with data in a way that patients and the organisations providing it is absolutely essential. Otherwise, you damage downstream possibilities.
Perfect. And perfectly timed, Mark. So thank you for an amazingly fascinating and really, really informative webinar. There's obviously an awful lot going on, and you've probably only just skimmed the surface, but to some of us, it seems like you've gone into great depth. It's lovely to have seen so many of you attending our webinar again today. Thank you very much for that. And thank you very much, Mark, again, for running this for us today.